going on, everybody? Welcome back to another episode of the Core Consults RX podcast. Cole and I riding solo today. No AJ.
No AJ.
He's busy.
He's moved on to bigger and better things after that award. It got sent out in a newsletter.
What?
Yeah, I know. And there's AJ's picture standing right there,
Oh, man.
winning the award for all like oral and written presentations at this whole thing, and
Oh boy.
like there he is.
We're never gonna hear the end of it.
I tell you what.
Nobody tell him that we're proud of him.
It was like AJ Alford, PharmD and PhD candidate, but
Yeah.
looked right
Oh, okay. You got two doctoral candidates.
he had a tie on too.
Did he? Oh my gosh, you wore a tie?
I think, unless I was looking at it wrong.
Yeah, well,
Yeah.
that's pretty good. We need to frame that picture.
Big for him.
I saw AJ present one time in a hoodie that was still pulled up over his head on a virtual thing. I was like, oh no. He did really well though. Everybody was happy about it. But it was when he first popped up on camera, I had a heart attack.
This is why he can't take episodes off, because we just make fun of him. the whole
Yeah,
time.
no, that's true. All right. So we haven't done one of these type of episodes since I think that antler trial came out.
Oh, was it?
Yeah. So we're going to just cover a clinical study today.
Yes.
And some of you guys have probably heard us mention this. I think we did a while back.
We've referenced it in at least 3 episodes that it was ongoing,
so
that I can remember.
the study comparing chlorthalidone and HCTZ has officially been at least reported on the findings. I don't think it's officially published.
Not that I can tell.
But the poster presentation was presented on the 5th of November. And so the study's the DCP, the Diuretic Comparison Project, which was done through the VA system. And basically patients came in, they were on HCTZ, and then they were either continued on HCTZ or switched over to chlorthalidone, and they were looking for basically cardiovascular outcomes, because the big issue or the big push for chlorthalidone, at least historically, has been there's outcome data with chlorthalidone, there's no outcome data with HCTZ. Meta-analyses, things like that seem to show that chlorthalidone is better, so why are we always using HCTZ instead of chlorthalidone? It's like a 10-to-1, which I would argue anecdotally is probably not even, that's a very very nice hat tip to chlorthalidone, because they've seen way
Right.
more people.
And you say historically, really that was a relatively recent change with the and within the last
2017.
decade, so within the last 5 years, right? And you say 10-to-1, so with the VA specifically, 95% of VA patients were on HCTZ if they were on a thiazide diuretic, 2.5% chlorthalidone
Yeah.
before this study.
The 12.5 you said chlorthalidone?
2.5% chlorthalidone, 95%
Oh,
hydrochlorothiazide.
percent. Gotcha.
Percent.
Gotcha.
Which
Like,
the
I thought
only
you said
other
milligrams. I was like, I'm not familiar with that.
No.
strength.
So the amount. So you said
Gotcha,
10-to-1.
gotcha.
So 95
Yeah.
with hydrochlorothiazide, 2.5% with chlorthalidone, which I guess means the other 2.5% must have been indapamide,
Maybe.
right?
Yeah. Which is a little bit of foreshadowing for you guys, because we're also going to introduce a little segment to the show called "How Would Cole and I Do This Clinical Study Better?"
How would we completely change it to make it much more relevant?
So, yeah, we'll look forward to that towards the second half. We just invented this show right now. We started talking about this study just off air, and Cole's like, hey, we should probably hit record. So here we are.
Save it for the podcast.
So, I guess, like I said, this study was something we've all been kind of looking forward to. The primary outcome that they were sort of looking for was adverse cardiovascular events, and it was a composite outcome. And Cole, spoil it for him. What happened?
Yeah. So, well, before that, I'll say that you've probably heard us talk negatively about HCTZ for a really long time. And so right when I saw that they were doing this study, I was thinking to myself, I bet you it's going to be non-inferior, just because we've been talking about it for a long time. I'm just so sure it's going to be non-inferior. Sure enough, it was non-inferior as far as their primary outcome of the composite of cardiovascular events. I do want to talk a little bit about just who was in the study and a little bit more about the setup. So it was open label. The patients knew what they were taking. I mentioned that 95% of the patients were taking hydrochlorothiazide before this trial started, which means that the majority of the patients in the chlorthalidone arm were switched from hydrochlorothiazide to chlorthalidone of note. So that may or may not be important. It was a large study. There was 13,500 patients. They were randomized in a 1-to-1 ratio to the normal treatment doses of HCTZ or chlorthalidone. The duration was 5 years. I think at the time of this poster, was it like 2.5 or something like that? Or was it the full 5?
For what's that again?
The duration that they've seen since they started. The follow-up is 5 years, but I don't know if they've gotten to 5 years yet.
Median follow-up is 2.4.
2.4. So
years.
2.4, I guess, so far. And all the patients are old, or should I say elderly?
They're above 65.
They're above 65.
Yeah.
So they're all over 65. The mean age was 72. And as you can imagine with a VA population, majority male, majority Caucasian. So it was, there were only 3% of females, 15% African Americans, and a paucity of Asian Americans too. So do with that what you will, because I mean it's almost all men that we're seeing, that we're looking at this in. So it really just doesn't give us a good gauge of what a female population or an African American population might look like. That being said, it was non-inferior. Mm-hmm. So I would say a win for HCTZ at least, compared to as far as how we've been talking about it for the longest time, right? And so you'll see some articles out there, one in particular from Medscape, that takes a pretty hard stance that this is like a vindication for all the providers who have been using HCTZ over the years, because it is majority HCTZ that is used, even though it hasn't had the data that we would have liked to see. And I don't know that I think it's necessarily a vindication for all of them. I mean, it's definitely makes me feel a little bit better about all the patients who are on HCTZ, but there's still some issues with this study. And then of course we're going to get into indapamide in a minute.
And I think the study or the review commentary article that Cole's talking about is the one from Medscape, right?
Yes.
It's literally called "A Win for Practicing Doctors and Science."
I know it's a bit of a biased seeming article.
I don't know about science necessarily, but so Medscape, Dr. Mandrola was the author of it, and he does make some good points though, as far as the study, how it was set up, and how the randomization was done through their electronic health record system and all that. So he does explain the whole process that went into it, on top of another Medscape article that really digs into the nitty gritty stuff of in a good summary of the study, at least the results published. But I agree with Cole. It's one of those things that I wouldn't say that it necessarily vindicates HCTZ completely, because there's still no placebo-controlled, randomized controlled trials that have used HCTZ that have prevented, or that has at least demonstrated cardiovascular outcomes.
Right.
Versus,
and this didn't either technically.
Right. And exactly. Yeah. And so it's one of those things where we do have that data with chlorthalidone from the SHIP trial, the ALL-HAD trial, some others. And, so I would say if you're just taking this one, you can't just definitively say, okay, well, there's still the same, still one study, and the way it was set up and stuff is not quite as right. There's still a potential for some, bias being on most of the patients were on HCTZ ahead of time.
Right. Which there, and that same argument in some ways can be made for all of the thiazide diuretics, because we're going to point out some individual data that we have with each of them, but you could point at any of those and say well, my patient might not fit into that, specific category, which is true. So that's completely valid. So it was non-inferior as far as the MACE, the primary major adverse cardiovascular events. In the subgroup analysis, there's a couple of interesting things that I don't know if you can really do much with this, but with the two groups, roughly 10% of participants had a prior stroke or MI. So that would have been secondary prevention. And they had an average reduction of 27% in MI, stroke, and heart failure deaths that were observed. And that was statistically significant versus placebo. That was for the chlorthalidone group versus, not placebo, but statistically significant versus HCTZ. That was chlorthalidone versus HCTZ. But for the patients without a prior stroke or MI, there was a 12% increased risk in developing cardiovascular disease when taking chlorthalidone versus HCTZ. So if you looked at that, it would look like primary prevention, HCTZ is better, secondary, chlorthalidone's better. I don't know if you can really draw that from this, though. It's just too muddy.
I really like what that, in fact, this is where I was going to give Dr. Mandrola, even though his article does seem a little biased, I really like his comments about the subgroup analysis. So I'm reading this, but basically he says that if you are tempted to make much of the MI stroke history interaction, first read the ISIS-2 trial and its subgroup finding based on astrological signs. So apparently they were trying to say based on astrological sign that's how you should base it. So he said
He's kind of sassy.
he is. Yeah, I like this guy. We need to have him on the podcast. If you guys know him, give him our number. He says subgroup findings in trials with null primary endpoints should be considered noise, not signal, until proven otherwise. I like that. That last part was pretty good.
Yeah.
It's like a mic drop.
Was that his last sentence of the article?
No, then he wrote, a naysayer might argue that because DCP won't change their practice, I already use HCTZ, that it's no big deal.
I didn't fully understand that sentence. I guess he's just saying like this isn't groundbreaking for me because I'm already using HCTZ. Right. Well, which you should also want studies to validate what you're doing too. Right. I would think, but
yeah, and I won't change their practice. I agree. Although I will say, yeah, I would make one argument towards changing your practice, but not with either of these drugs.
Right.
So the other thing that the study showed, which we all probably would have guessed, hypokalemia was higher in the chlorthalidone group, and that was statistical significance. So 3.1 or less than 3.1 was considered hypokalemia. So the one thing I will say, because we did get a statistical significance with hypokalemia, I'm curious to see if anybody's looked at this or if they're going to do a secondary analysis where they basically eliminate the patients who had hypokalemia and just looked at the normal kalemia patients to see if then there's a difference between HCTZ
and not just hypokalemia, but if just take out all the patients who were on chlorthalidone that went below 3.5, right?
Yeah, right. Because where it's coming from is the SHEP trial, which was one of the outcome studies, showed a positive outcome risk reduction with chlorthalidone over placebo. But when they looked at a secondary analysis and saw that when they separated them out based on patients who had a low potassium, so below 3.5 or in the normal range, the patients who went below that 3.5 basically lost their cardiovascular protection, the outcomes went away. So with this, because that's statistically significant on hypokalemia in this study, if we get rid of those patients and just reevaluate the data on the ones who did not have hypokalemia, I wonder if there'd be a different result.
Right. And I feel like there would be something different for sure based on our knowledge of that. And I mean, and that goes along with what we've always recommended for chlorthalidone in this instance, is if you're going to use it over HCTZ, you need to make sure that their potassium is above 3.5.
It's just one of those things that that's one of the things I have an issue with chlorthalidone, and I've heard a lot of other clinicians say I don't like chlorthalidone because of the hypokalemia, and that's true. I've seen it happen in multiple patients. Hypokalemia is a real issue with chlorthalidone. That's one of the reasons I don't like it as much. Mm-hmm. So that's the DCP in a nutshell, a very abbreviated nutshell.
Do with it what you will. I'm not sure it at least makes me feel a little bit better about HCTZ.
Yeah,
at least makes me feel a little bit better in certain situations.
Yeah, until it beats out indapamide, that's still going to be trash in my book.
Right.
No, but the joke I was saying earlier about Cole and I setting the study up, and the reason we decided to kind of talk about it here is because on like on the podcast Instagram page and stuff, we had a few people when I posted the picture of this study and all that in the stories. I had a few people ask, because I put in the comments on there, but why not indapamide instead of chlorthalidone? So I had some few people reach out and ask, well, why indapamide? So I figured, why not?
Let's tell them about it.
Let's tell them about it in bulk. We're gonna CC all of you. and so if you've been listening to our podcast for a while, you've no doubt heard us talk about indapamide, probably till you're sick of it, but we're going to review it. So there's a few different things, to touch on. One, indapamide is been around for a really long time, just like the other two have. It also is a thiazide-like diuretic that has outcome data, just like chlorthalidone. So it's been studied in really elderly patients, so 80 to patients over 100 years of age in the high vet. It's been studied in patients who have previously had an ischemic stroke. In the progress trial, it was compared in patients with diabetes that had microalbuminuria in the Nestor trial. So there's definitely been some solid outcome data studies that have been conducted with indapamide, so we know that it does ultimately reduce the risk of cardiovascular disease. Right.
So and when you hear about thiazide plus ACE in post-stroke patients,
it's indapamide.
That's indapamide specifically, progress trial. So we do have a lot of good stuff with it.
Yeah. Plus, when we think about patients with CKD as well, HCTZ, we typically, your creatinine clearance drops below 30, below 25. We tend to, not really think of HCTZ as being all that effective, because it's not helping. The diuretic effect is not helping anymore, and you worry about an acute injury at that point from dehydration things. So indapamide, however, does actually have renal dose adjustments down to 10 mils per minute, and has even been compared head-to-head in patients, HCTZ versus indapamide, in patients with CKD, and looking at its effect on eGFR over time. And there's been a couple of different studies like that, but one of them in particular, the patients had the baseline eGFR in the HCTZ group continue to decline, which we kind of would expect. However, in the indapamide group, the eGFR actually went up a little bit from baseline. So you can't really, because of the way the study was set up, you can't really say it's like nephroprotective.
Right.
But we definitely know that it's not harmful
Negative,
on the kidneys. So, from a mechanism standpoint, in certain patient populations, it definitely seems to be better. Blood pressure lowering, it's definitely a better, any meta-analysis you look at, there's a lot of them that show, maybe 10 millimeters mercury difference systolic lowering with indapamide versus HCTZ. And I will say this is one where anecdotally, I think, or, from a clinical experience, it is relevant, because we started using indapamide, like everybody who was on HCTZ, we were just switching everybody. And we were able to stop like other blood pressure medications after making that switch, even if we used the equivalent dosing. Like we just got so much better results with indapamide, just from a blood pressure control standpoint from appointment to appointment.
Right.
So it definitely seems to lower blood pressure a lot better, especially with HCTZ being dosed once a day.
Yeah.
Typically, because then you got to think about the half-life.
Right. So less side effects to be concerned about. We talked about hypoclemia with chlorthalidone. There's also glucose issues possibly with HCTZ, right? Is there gout issues with HCTZ too? Uric acid issues?
So indapamide technically has one of the more uric acid reabsorption rates. HCTZ is still there as well.
Yeah.
So all of them can reabsorb uric acid, but that tends to be like slightly elevated, like so the serum uric acid tends to go up slightly and then come right back down again pretty quickly.
Yeah.
Because a lot of it, you're just sort of like the diuretic effect of a thiazide or so is only really lasting about a couple weeks, and then you're basically kicking in the RAS system and working on the periphery and some other things as well, which we can talk about some of the mechanistic changes a little bit further in a second. But what you were going about with the side effects, hypokalemia, like I think that's the big one that I always think about with indapamide. It's got the least amount of potassium wasting. There was let me pull this up. There was there was a study that looked at potassium wasting in patients who were either on HTZ or indapamide. I think, let me make sure this is the right study I've pulled up. I believe the amlodipine was also included in that study, but it didn't have like a actual name associated with it. It's an old one, 2001, I believe. But so basically they were showing this, and other studies have showed that HCTZ will have a statistically significant increase in hypokalemia cases versus indapamide. And so I think of it as being a much less concern from a potassium wasting standpoint.
How does it do with sodium? About the same?
Yeah, I don't. I mean, you never with the thiazides. I feel like it's not the sodium hyponatremia isn't nearly as big of a concern.
As potassium.
Yeah. You mentioned glucose.
Yeah.
So one of the things I always think about, and I've mentioned this before, so sorry if this is a repeat, but one of the things I always think about with glucose reabsorption with HCTZ, technically speaking, it's not what we think of as clinically relevant a lot of times. Although I will say there was a study back in, when was this? 2006. It's called the Comparative Assessment of Hypotensive, Metabolic, and Endothelial Effects of Indapamide and Hydrochlorothiazide in Patients with Essential Hypertension. So much longer title than some cool name. But basically showed that from a metabolic standpoint, you have a lot more risk of developing glucose intolerance or higher glucose levels, higher fasting glucose levels, higher lipid levels even with something like HCTZ versus indapamide. And even though we don't typically think of that as being clinically relevant, SGLT2 inhibitors are becoming a much bigger and more widely used class. And so if you think about those mechanistically, if an SGLT2 inhibitor is blocking glucose reabsorption at the proximal convoluted tubule, pushing all that glucose through the nephron, it hits the distal convoluted tubule where the thiazide, like HCTZ, is working. And now you have a lot more glucose available for reabsorption than you would if that SGLT2 inhibitor was not there, lowering the glucose reabsorption threshold. And so at that point, does it then become a little bit more clinically relevant? Because I haven't seen anything that actually shows or has looked into that. I asked a couple of the medical science liaisons and I couldn't get a clear answer if that's ever been looked at on their end.
Right.
So it is more theory, but because HCTZ being so widely used and SGLT2 inhibitors is still something I think about. Am I offsetting the effects of the SGLT2 inhibitor by using HCTZ? And indapamide having basically a neutral effect on glucose reabsorption, we kind of overstep and get past that little caveat.
Right.
So I think that's something to kind of keep in mind too. I'm hoping eventually some data comes out about that. I'll have my answer eventually. But so from an electrolyte standpoint, indapamide's so much better, much better potassium, uric acid. If they have a history of gout, check to see if they are on allopurinol. If they are, I wouldn't be worried at all about the uric acid piece of it. If they haven't had a flare up in a while, just maybe warn them to keep an eye on it. Maybe have something on standby if you're worried about it. But it's most likely not going to be a huge issue, especially if they're on a xanthine oxidase inhibitor or something like that.
Right.
So the electrolyte's definitely better. I mentioned half-life earlier, and what I meant by that, just to elaborate a little bit further, if you look at the actual half-life of HCTZ, it's like around 12 hours. So just like with like lisinopril and losartan and some of these meds that we dose twice a day to get better blood pressure lowering, technically speaking, HCTZ would need to be dosed twice a day, really, if you want to optimize the half-life and the dosing correctly. That being said, chlorthalidone and indapamide have much longer half-lives. Chlorthalidone's is the longest, and they're true like once-a-day medications. So I think that also may play a role in some of those meta-analyses and things that have showed it's got numerically better blood pressure lowering ability, which, we've talked about before, doesn't necessarily mean anything, but if we are just trying to get a patient to a goal blood pressure, that obviously can help without adding on other medications.
Right. Yeah, because we have less side effects, better blood pressure lowering, and if we can prevent the addition of another medicine, that unless we're trying to specifically get outcomes from it, we would definitely want to do that.
Yeah. So, that's just some of the things to kind of consider. Mechanistically, there's also a lot of differences between them. So, for example, when we think about like calcium channel antagonism, like calcium channel blocking properties, absolutely none with HCTZ and chlorthalidone. Indapamide actually does have calcium channel blocking properties. So it also has a negative effect. There's no effect whatsoever on calcium dependent or potassium dependent calcium channels as well, in the actual nephron. And it's got some other some oxidative stress reduction qualities and some other things that can basically affect the periphery and decrease some of the other peripheral vascular targets that we go after with blood pressure medications, much more so than the other two would. So if you want to like do like an in-depth kind of review of this, check out the article called Redefining Diuretics Use in Hypertension, Why Select a Thiazide Like Diuretic by Michael Bernier, George Bacris, and Brian Williams. It's really, really good review. They go through some of the actual pharmacology of the drugs. They go through a ton of the studies. It's a really, really good literature review. They go through patients with diabetes versus elderly versus, all kinds of stuff.
And they look at all three. Of course, the thiazide likes are indapamide and chlorthalidone.
Yeah,
versus
they look at all three.
The thiazide, which is HCTZ, but they looked at all three, and they They give the pros and cons of chlorthalidone versus indapamide too as well.
Yeah. And also they give the actual, I mean, you can go through their references and find all the studies we ever talk about.
Right.
So if you're interested in that, definitely check that out. Again, it's redefining diuretics use in hypertension. Why select a thiazide-like diuretic? Google it; it'll come right up.
So what would be, other than gout, possibly any reason to use, let's say, HCTZ over indapamide? Any possible reason?
My thing would be if a patient's just unwilling to take anything but a combo.
Yeah, that's what I was.
That's
thinking.
where I
because
tend
indapamide that I'm aware of is not in any combos. And HCTZ is in combos with everything.
I wonder. I bet you.
Primarily ACEs.
Why is nobody compounding, making the world's greatest, compounded blood pressure?
Well, because the prescribers probably aren't prescribing it. You know what I mean?
Yeah.
If they felt like there was a market for it, like if prescribers were like, man, I really would prescribe indapamide if it came in combos.
Yeah.
Then maybe they would.
Maybe.
But also, who would pay? Like you'd have to, the whole. Like if they were like, okay, I'll compound it, but it's $10 a pill. They're like, wow, I'm still gonna go with the cheap HCTZ combo.
Yeah. We'll come up with this scheme later off the air.
We'll figure it out.
We'll figure it out for you guys.
We'll
It'll be our next venture.
Yeah.
As our compounding pharmacists are like these idiots.
I have no idea what they're talking about. Two guys who've never done anything compounding.
Listen, I did a class once.
As did I.
No, I did another.
I shadowed a compounding pharmacy
Did
for
you?
like a day.
You did a rotation with one, didn't you? No.
I did a rotation with a independent that had retail, specialty, long-term care, compounding, and a medical supply store that had like the whole shebang. And so I spent some time with compounding then, but that was it.
Yeah. Well, that's probably more than me. I did like a 3-day certification, it was like an internal certification thing through Walgreens, so it meant nothing. But I went to the class and made a bunch of stuff that wasn't all that great.
I remember studying something related to compounding and having to take an exam about something. Maybe it was just a class, I don't know, but for school. But I thought it was post-grad. I did something with compounding, but I can't remember.
Too busy.
It's too many things.
Too many things you've been involved with, Cole.
I guess.
You need to slow down. Anything else with this stuff? I
No,
know a lot
think,
of it's review, obviously.
I think this is good because this is, especially once it's actually published, I think it'll be more out there. But this trial is a big deal, and people are going to make a big deal of it. And I think there's something to be taken from it, but just take it for what it's worth. Since we have indapamide, if it was truly between HCTZ and chlorthalidone, I think this would raise a lot more questions.
Yeah.
But since we have indapamide, I just don't know. It feels like it could have been worth more if they had looked at indapamide.
Yeah. I mean, to be totally honest, if I only had those two to choose from, I don't know that I would pick chlorthalidone either because of the hypokalemia.
Right.
Literally.
And with this,
yeah.
If it was just these two, I think that this
would justify for a lot of patients.
Would justify for a
not
lot of
taking
patients to be
chlorthalidone.
on HCTZ. But since we have indapamide,
jury's still out, at least in my book.
So do you think it puts chlorthalidone at the bottom now?
Maybe.
Yeah.
Maybe. I mean, probably for me. I mean, to me, it's always been
now. I don't even know if I have a preference.
Yeah. I mean, I don't have I would say if I was again.
So it's always been HCTZ and indapamide for you. I feel like I was on a chlorthalidone train for a little bit when that guideline came out.
I was I think in 17, 18, and then I started reading more into indapamide because I definitely switched. I was more on chlorthalidone just because it's the one with outcome data and stuff initially.
Yeah.
But you don't really hear people talk about indapamide. Cost is not an issue either. It's like last time I checked, it was $4 list at Walmart.
Yeah.
So it's it's not. I don't know. I don't get why. And most people have. I've talked to physicians that have never even heard of it.
Now people do use it because we dispense it. So I'm interested to know who is prescribing it. I wonder if it's the cardiologist.
Maybe.
But it just does. They don't get on it until they get to the cardiologist.
I know. My old clinic at Feder, a ton of people are on it now because I was pushing hard for indapamide, and so I remember one of the new physicians that had started there towards when I was leaving. It was like, I've never had heard of indapamide. I was asking me a couple questions about it, and it was like, yeah, I've just noticed that every one of these patients is on it. I was like, yeah. Very
that was
meticulously moving my chess pieces. But so yeah, that's our 2 cents on that. I'm definitely curious to see what you guys think. If any of y'all have any thoughts or anything, let us know. But I think indapamide needs to be a head-to-head study eventually.
Now that you're gonna have kind of a new patient population, you're gonna be able to make some moves there with indapamide.
We'll see.
Yeah,
Curious to see what they say.
Yeah.
But all right, guys, we'll close it off with that then, I guess. If you have any questions, definitely send us an email. Make sure, if you have not done so already, check out our sponsor Pearls, pyrls.com/CoreConsultRx. It's a fantastic drug info app that has a desktop application as well now for those of you who don't necessarily spend all your time on your smartphone. And so definitely a very cool info or drug info app. They have lots of algorithms and, pharmacotherapy tidbits and clinical pearls, hence the name. But they've been a big help to Cole and myself, so make sure you check them out. And if you do pearls.com/CoreConsultRx, you can sign up for a free account, and you'll get access to some free PDF files of pharmacotherapy regimens and guidelines and whatnot. And then if you like it, check out their pro version as well. And also, for those of you who like the lecture style topics where we're not just getting off topic and giving our opinion on random stuff, check out patreon.com/CoreConsultRx. Pharmacotherapy lectures, pharmacology lectures that I do for the PA school. A lot of the same content goes on there. And so check those out. They have PowerPoint slides you can download. It's probably the cheapest review program on the planet. I think this week I posted on Crohn's disease, or I'm about to post on Crohn's disease tonight, and there was one on hypothyroidism last week. So check it out. There are lots of random topics. So give that a shot. And if you have any questions, emails in the show notes, cell number you can text us at is in the show notes or on any of the social media platforms. We'll see you guys in the next one. Have a good night.